ladies and gentlemen, we are about to commence this evening's event. We ask for your continued cooperation and wish that you have an enjoyable session. For record purposes, please ensure that you are signed in with your full name, first, then last name. Necessary changes can be made by clicking on your name, whereby you'll be given the option for any alterations. Lastly, we would like to inform you that this event is being recorded for storage and archives. Therefore, to ensure the integrity of our production, we kindly ask for your audio and video functions to be turned off at this time. Thank you once again for joining us this afternoon and for your cooperation. It is now with great pleasure that I hand you over to our Secretary, Nathalia Ali.
Thank you, Vanessa. Good evening, ladies and gentlemen, and a special warm welcome to our invited guests and colleagues from the Mona and Keyville campuses. I am Natalia Ali, the Secretary of the Pathology Club of UAE. I would like to thank you for joining us for what is to be our 14th installment of CPALMSI. Today, I have been given the honor of introducing our guest speaker, Dr. Raghavendra Pillappa, who would be sharing a very informative presentation on pulmonary pathology. But before this, I would like to give a brief introduction to the outstanding contributions that Dr. Raghavendra Pillappa has made in the field of pulmonary pathology. Dr. Raghavendra Pillappa is the Director of Immunohistochemistry and Assistant Professor of Pathology at Virginia Commonwealth University Health System. He obtained his Bachelor of Medicine, Bachelor of Surgery from Sri Devaraj Medical College in India, followed by a postgraduate degree in pathology from Karnataka Institute of Medical Sciences. During this time, he secured the prestigious Rajiv Gandhi University of Health Sciences Gold Medal for scoring the highest marks in the University Pathology Examination. After his education, he worked as an assistant professor in pathology at Sri M.B.B.S Medical College and Research Hospital, following which he moved to International American University in St. Lucia. After completing his AP residency at the University of Tennessee Health Science Center, Dr. Pillappa went to the Mayo Clinic in Rochester, Minnesota for 2 fellowships, general surgery pathology and pulmonary pathology, with a special interest in breast pathology. Additionally, he has special interest in interstitial lung diseases, in which he read a large number of surgical lung biopsies at Mayo Clinic during his fellowship training. Without a doubt, Dr. Raghavendra Pillappa is a motivating figure for us in the M.B.B.S program, aspiring surgical or pulmonary pathologists, and most certainly in pathology. An inspiration to many, we are all honored, pleased, and privileged for him to be here with us this evening. So, ladies and gentlemen, I ask where you are to welcome Dr. Raghavendra Pillappa.
Thank you for the kind introduction. So now I can share my presentation?
Yes, you can.
Okay. Can everybody see my presentation?
Yes, we can.
Okay, great. Okay, so the next 45 minutes, I'm going to talk about how you can get your career in pulmonary pathology. So, like you mentioned, my name is Raghavendra Pillappa, and currently I'm a staff physician here at Virginia Commonwealth University. So, since I've been a fellowship trained pulmonary pathologist, so I thought I will give you all the options and all the different paths and different tips and what do you say? For this getting into the pulmonary pathology. So this is a book by Laura Driscoll, published in 2018. So it's a cartoon book, but still it's very effective. It's available on Amazon for less than $5, but it just tells you how you can create that awareness in a kid about what a pathologist does in the lab. So you can see here, this Dr. Lopez works in the lab. So it looks at the test to see what is making someone sick, or it's like putting the puzzles together or solving mystery. So it's a nice little way of telling kids what we do in pathology. So it's a book available in Amazon if you want to ever read it. So coming to the outline of my talk, these are some of the headings I'm going to cover. First is relevance of pulmonary pathology, then list of training opportunities, required qualifications, and an academic year, how a academic year in a pulmonary pathology fellowship or a training program would look like. What are the different responsibilities when you're a fellow, as a fellow of the Pulmonary Pathology Fellowship? Then once you finish the fellowship, what are the different opportunities, or how do these opportunities look? And what is the current scenario or state or trend of job opportunities in the field of pulmonary pathology? And then organizations, some important national, international level organizations and their websites and social media presence, where you can have a tons and tons of information which can be useful for your path towards pulmonary pathology. So what exactly is pulmonary pathology? It's a branch of anatomic pathology. Now, the pathology is divided into anatomic pathology and clinical pathology. Anatomic pathology deals with the tissue specimens, while clinical pathology deals with all the fluids and blood and urine and all kinds of liquid material. Okay, so you have tissue, anatomic pathology, and clinical pathology is all liquid material. So pulmonary pathology is a branch of anatomic pathology where it deals with the diagnostic and prognostic aspects of a thoracic neoplastic and non-neoplastic diseases. So it's mostly in the thorax, that is, it deals with the lung, deals with the mediastinal tissue like thymus, mediastinum, trachea, and then the chest wall, pleura. Those conditions are diseases. And both, even though our practice predominantly covers the adult patients, but still we do have pediatric patients coming our way, especially congenital conditions or infections. And then the pulmonary pathology includes thoracic oncology, where the neoplastic or the cancers are dealt with. And then interstitial lung diseases. These are the fibrosing lung diseases. Then transplant pathology. And the setting, like I mentioned before, it's mostly in the tissue. That's what we're dealing. So it could be wet tissue. It could be slides from outside institution where the patient already had kind of a diagnosis in outside institution, but because they're transitioning to a different institution for patient care or a surgery or further management or a chemotherapy, then we get those consult slides. We get those slides and we look at them, we agree or disagree with the outside diagnosis already rendered so that we can help the patient for further management. Then autopsy. So many times autopsies come as a consult for me in my practice. My colleagues who are doing autopsy, I don't do an autopsy, but during the training, we do go through the autopsy, doing the autopsy and everything. But in my practice currently, I don't do autopsy, but I very often get to see the autopsy specimens, especially autopsy lungs, because my colleagues usually bring it to me asking for a question about the cause of the findings. Can those cause of the findings can explain the reason for the death, the immediate cause of death, something like that. Then lung explants are these lungs which are removed as part of end-stage lung diseases, and then the patient would get a new pair of lungs. That is what the transplant world looks like, where your old organs, which are already pathologic because of some kind of disease process, are taken out and a new pair of lungs, compatible lungs, are given. So we deal with all these in pulmonary pathology. So I want to show you some relevance of pulmonary pathology. On the left upper corner, you can see here so proteomic analysis of human lung development just came out, a recent article. So proteomic analysis is it's the first in-depth characterization of the human lung proteome, that is the proteins in the lung. So before that, whatever knowledge we had was based on the animal studies. And this is one of the first in-depth characterization in a human lung kind of tissue. And it gives a lot of understanding about the lung development, the different stages of alveolar development, the alveologenesis, or even the post-transcriptional control in the postnatal development of the lungs. And again, if you go to lungmap.net, you will see the free access of the same thing. And then the National Library of Medicine, which is also called PubMed, that's where you will see all the medical peer-reviewed literature archived and everything, or published. So once they publish in the journals, they get archived here. So one of the recent hot of the press article was smoking prevalence during COVID-19 pandemic in United States. So why I bring up this smoking is we can see smoking related changes in the lung as a pulmonary pathologist. So every single day whenever I see the lung tissue, I see the smoking changes if the person is a smoker. So even if somebody does not give me an history about the smoking status in a patient, I can still tell that this lung belongs to a smoker for a set of changes what I see under microscope. So that's the power of the specialty. And let me bring you to another important article which came in American Journal of Clinical Pathology in 2020. So you can see this COVID-19 autopsy, Oklahoma, USA. This was the first report of complete autopsy finding on COVID-19. So they only did 2 cases. So 2 autopsies were done who were positive for COVID-19 or SARS-CoV-2. And the authors, they described the pathology findings in the lungs and all the organs. And the last author is the pulmonary pathologist. So you can see the power of pathology here so it's important to describe these findings to understand what is happening in these people infected by new things like COVID-19. Tomorrow we might get something new. So it's important to understand this by looking at them under microscope. So just before the COVID-19 pandemic in the US, there was this big cluster of cases, especially in young men and women, like kids. And most of these kids were coming with a vaping kind of history, and they're coming with acute respiratory failure. So that's what you can see here. E-Valley is e-cigarette or vaping product use associated lung injury. So if I go to a petrol station or a gas station here, these things, the nicotine delivery systems are available as small as a USB pen device, shaped kind of a thing. So, but the bad thing about this is it not only causes health risk in these kids, but also it can lead for them to get into what is called as nicotine addiction. And then when this vaping kind of cases were becoming prominent, the Mayo Clinic people, they described this 17 cases. They looked at 17 patients and they described, I think they sent it to New England Journal of Medicine, which is kind of a big journal. And they described that the lung damage from vaping resembles chemical burns. So there was an interview by Brandon Larson, who is the last author on this, who is a pulmonary pathologist. So pulmonary pathologists from Mayo Clinic from different locations and other collaborators, they come up with this a presentation or article in New England Journal of Medicine. So I'm trying to tell you the relevance of pulmonary pathology here, that the pulmonary pathologist is responsible for identifying these findings to help in the social cause of different types of challenges we encounter. So now the question is, now that we know the relevance of pulmonary pathology with those examples, why do you need this specialty training? So before going to the pulmonary pathology training, let's go to a pathologist training or pathologist as such. So the data I'm showing you is only US and Canadian pathologist workflows. So this article in JAMA 2019 was trying to compare between pathologists in US and pathologists in Canada. And they were trying to compare this with other specialty doctors. You can see the graph is going high or going up for anesthesiology, radiology, both in these countries. Even for in Canada, pathology was also going up, but in the US, it was going down. But in the same period, the number of physicians were going up. So despite increase in the physician, the pathology workforce were going down. So that was the study on this one. So, and then they said the shortages of pathologists in general would result in suboptimal patient care because there could be a delayed cancer diagnosis and diagnostic errors. So that was 2019 in JAMA. But 2020 in JAMA, they looked at re-evaluation of the US pathologist workforce size because the previous report said the pathologist workforce is going down. But now they said that the next year they said that the previous report only had selected pathology category, it's not complete. It was not completely, all categories were not completely included. And they said that the current AMA, American Medical Association Physician Master File, actually suggests that the pathologist workforce may be increasing. But they also said that more clarity has to be used to look at the counting and classification methods. So they hypothesize that there could be an artifact in counting and classification methods, so it needs additional clarity. But whatever it is, the pathologist workforce is maybe increasing or maybe stable at this point of time. But going forward, we need more and more pathologists. That's what I'm trying to say. And more so pulmonary pathologists. Again, why this training, pulmonary pathology? So this article, even though it's a single study, single institution study, where they looked at a 83 patients, retrospective analysis of 83 patients in a single institution. And this was pertaining only to interstitial lung disease. So again, the interstitial lung disease, it's not the predominant type of cases we see in pulmonary pathology practice. In pulmonary pathology practice, most commonly we see is lung cancer patients, lung cancer specimens. But the interstitial lung disease is one of the most important things relevant for us because that's where we come into the play. That's where our expertise comes into the play. So based on this study, they said that the histopathologic interpretation, there was a big discordance between the generalist and the pulmonary pathologist, and this discordance was up to 52.3%. And again, the discordance, obviously, whenever there's a discordance, there's always important clinical implications. Even though this study was at the Armed Forces Institute of Pathology, where most of the consult cases used to go there, and again, the bias would be that the most difficult of the difficult cases would go here, not your straightforward cases. So you can say that the difficult ones can be discordant even between pulmonary pathologists. But still, there is a point here they tried to prove that there is a discordance between somebody who has a dedicated pulmonary pathology training and a general pathology training. So with the reasons why, that's why you need pulmonary pathology training. And let me tell you more about what are the different opportunities and why you should choose this specialty before the end of this talk. So now, what kind of specimens we see in pulmonary pathology? Like I mentioned to you before, look at the tissue. It could be small tissue in the form of biopsies, or it could be larger tissue in form of resection specimens. I do have some microscopic appearances here, so which I'll show you in the next few slides, but these are the different types of biopsies. So the interventional pulmonologist usually does these smaller biopsies like transbronchial forceps biopsies. That means they go through the airway route, pass a little tube and everything, and they can look at the tube. As at the end of the tube, there's a camera, so they can look at the monitors for guiding their location, and also to view the airway and everything. So the bronchoscopic route. So there are different types, transbronchial, endobronchial, and recently there is a lot of push towards transbronchial cryobiopsy, where they use a freezing bioptome to freeze the tissue when they touch the area of the lung, and then they pull it back so that a bigger chunk of the tissue comes along with the biopsy instrument, compared to this previous two types of biopsy. And then we have what is called as needle core biopsy, where whenever there's a nodule or a mass lesion in the lung, when they're suspecting cancer, they put a needle and try to get a core biopsy. And then surgical lung biopsy is the one which we do for interstitial lung diseases. And then there are different types of resections done for cancer related processes. Like if you remove a small piece of lung, it's a wedge resection. If you remove the entire lung, lobectomy, segment of the lung, segmentectomy, the entire left or right lung with the tissue around it, it's a pneumonectomy, which is kind of an extensive surgery. So these are the different appearances of the different types of biopsy I showed in the previous slide. Transbronchial forceps biopsy is the smallest one, whereas the transbronchial cryobiopsy is, you will find a little bigger chunk of tissue where it's useful for us to make better diagnosis, while the biggest piece of tissue we get would be in the surgical lung biopsy, where we get tissue from different lobes of the lung. And that's very useful for us to make diagnosis, especially in terms of fibrotic lung diseases or end-stage lung diseases. Well, the needle core biopsy would look like this. It's shaped like a needle, like a core needle, elongated, like a tube-like structure. And generally, they're able to see a mass lesion like a 2 centimeter or a 3 centimeter nodule in the lung, where they're able to go inside, target it with a needle, and get a biopsy of that. In this case, it's a diagnosis of metastasis, not a primary lung cancer. It's a diagnosis of metastasis in this core biopsy. It's a metastatic carcinosarcoma in a patient with a previous uterine carcinosarcoma. So surgical lung biopsy, generally these are done to evaluate for any fibrotic lung diseases when they are not able to get the diagnosis from other modalities, including clinical modality, like if they're looking at some antibody testing to rule in or rule out connective tissue disease, or even hypersensitivity pneumonitis, where they're trying to look for any organic antigen exposure by doing a serologic kind of test. And then the other important piece of the puzzle is look at the radiology, because a radiologist can look at both the lungs, while the pathologist can only look at the tissue what it's given to them. So I can only tell what's going on in this piece of lung, not in the remaining lung, which only the radiologist can tell us. So it's important to talk to the radiologist and the pulmonologist when we are thinking about a interstitial lung disease process in question. So I'll show you an example later on when we get there. But right now I'm just showing you the different types of biopsies and different kinds of, what do you say, uses of these different biopsies. So this is just a picture of what is called as DAD, diffuse alveolar damage. So in your medical school, they must have shown you this hyaline membranes in the lung. So whenever you see hyaline membranes, the pink membranes lining the alveolar spaces, that's nothing but diffuse alveolar damage. The arrows here are showing also some thrombi in the blood vessels, which is part of the DAD, okay? There can be other changes accompanied by this diffuse alveolar damage or hyaline membranes in the form of type 2 reactive pneumocytes. And sometimes you can also see some squamous kind of epithelium in the lung. So again, these are all part of acute lung injury and what we call as diffuse alveolar damage. Clinically, these patients present with acute respiratory failure and their oxygen saturation is falling down, so falling low. So the clinical syndrome is called as acute respiratory distress syndrome, but pathologically, when we see these findings, it's called diffuse alveolar damage. So I want to bring your attention to this COVID-19 article, which is from my program director at Mayo Clinic, Dr. Rodan. So that so many articles came. This was one of a well-written article. They described the findings of COVID-19 patients with nice cross images showing the thrombi here in the blood vessels on gross appearance. And also they showed not only you'll find DAD, but there's some of the patients also had some bronchopneumonia infection in the lungs. And switching to EVALI, the e-cigarette or vaping product use associated lung injury. So why I'm showing you these tables is this is from an article from Matt Cecchini, who is one of my friends at now he's practicing in Ontario. So so you can see there's pathology criteria here. There's also radiology criteria you can see here. And there's also testing criteria. That means we can diagnose this EVALE only when we rule out that and another cause of DAD, because most of these patients will have varying amounts of acute lung injury. The extreme form of acute lung injury is diffuse alveolar damage, whereas there is also what is called as subacute forms of acute lung injury, which is called organizing pneumonia. So, and there can be other non-specific changes. So for us to say it's because of EVALE, we have to exclude other infections or other causes by appropriate testing. So to get to the definition of EVALE, that's why the CDC, the Centers of Disease Control, has showed you this kind of table where confirmed case has got this clinical, radiological, and pathological findings. Well, if one of these criteria are not there, then it's a probable case of EVALE. So I'm just trying to tell you the power of pulmonary pathology as of the pathology. As such, the findings is so important to integrate along with the clinical findings. Then there's some images of different kind of infectious organisms in the lung. You can see examples of Aspergillus, Pneumocystis jirovecii, Cryptococcus. So obviously these are special stains. Means I'm not trying to tell you some pulmonary pathology disease process here, but what I'm trying to show you is different spectrum of conditions to tell you the relevance of pulmonary pathology. Because once we make a diagnosis of Aspergillus or a Cryptococcus or a Pneumocystis, it's a definitive diagnosis. That means the patient can be treated with a drug rather than exploring further, looking for the diagnosis. Because most of these clinical manifestations would be similar. And then one, two symptoms they can expect in a respiratory kind of ailing patient is cough and shortness of breath. So most people with lung symptoms come with cough and shortness of breath. fever if there is an infection with bacterial kind of etiology. But the pathology can help in making a definitive diagnosis here and leading the clinical team to give them a drug which is effective against what's going on in their body. So that's what I'm trying to tell you here. And you can also see some foreign material, like on this side, you can see this colorful stuff here. So the blue stuff or the coral-like or the purple, these are cross-povidon, and the pale stuff or the colorless one is microcrystalline cellulose. So this condition is called a tal granulomatosis, and this is generally when the pills are injected into the blood by IV drug users. So when they get injected into the drug pills, when the pills are injected, these are called pill fillers. So they also get entrapped in the lung, blood vessels and everything, so which can be seen. Contrary, on the left side, what you're seeing is aspirated material, like a vegetable. Sorry for the fold here. Vegetable material and then other foreign material associated with giant cells. So we can tell if it's an aspiration or injectable kind of material in the lung based on the location where they're present. And also sometimes we are able to tell the type of material also. We can tell if it's a meat, kind of aspirated meat, or if it's a lentil, or if it's a vegetable matter, or if it's something else. So there's a list of things we can tell. Not everything we can tell, but at least we can tell them what might have gone wrong. And then here you can see these macrophages in the intraalveolar spaces, they've got a fine yellow granular pigment, the yellow kind of pigment. Those are smoking pigment. Unlike on the right side, the golden brown pigment is more chunkier. That's more of a hemocyanin-laden pigment. So with the appearance, we can tell what kind of etiology or what kind of process is going on. So what's pulmonary pathology for the clinician? So I know we are talking at a different audience here, but I wanted to tell you this, that no matter whom you're talking, unless you have the complete history and the context of the patient, no amount of accuracy would not help you. That means whatever you see under microscope, it has to be put together with the proper clinical context and clinical history and proper available clinical information. It could be in form of history to exposure to this and that, history of exposure to a bird or exposure to smoking or comorbid conditions. If a person has got a drug for an autoimmune condition, so that matters a lot for the pathologist to make a proper diagnosis. And when we have the history and when we put all the things together, that can add the value to the diagnostic process and optimize the patient management. So that's what I'm trying to say here. So having spoken about relevance and the power of pulmonary pathology, let's move on to what are the different opportunities or different things available. Again, I'll be more biased towards the US opportunities because it's easily available, in the sense you can just Google them and the list of the things just comes up. In UK, there is no formal training fellowships available, but in the US, there are several fellowships available for pulmonary pathology. And even though I mentioned there's no disclosures, financial disclosure, I have to disclose that I'm a digital content committee member for Pulmonary Pathology Society, but it's a voluntary activity. So Pulmonary Pathology Society is a great place to look at for fellowships, list of fellowships. There's also some other resources available here, like case of the month, especially as a medical student or a student in pathology. We have several interesting cases every month where it's educational. And then memberships are available. And there is several resources available where Biannually, there is a meeting of Pulmonary Pathology Society, and the materials are posted here. And you can also attend meetings at a nominal amount if you're a student or if you're a resident. So what I'm trying to say here, the list of fellowships opportunities are available with the contact numbers and the emails and everything, the program directors and the coordinators and everything. So these are some of the things I compiled. This is what I found. This list is, it's means I'm not going to tell you that it's the most complete list. I did the best to compile the most accurate kind of institutions and everything. But if I missed anything, let me know. We can always add to this list. And if you come across a new kind of program, let your friends know who are interested so that they can get the full benefit of it. And like I have seen Catherine's presentation in the YouTube, so I would echo the same thing, that the pulmonary pathology fellowships are usually tied up together with cardiac fellowship, the cardiovascular fellowships. And most of the places you can see it's cardiovascular and pulmonary. I trained in Mayo Clinic, Rochester, but there are several other areas, California, Chicago, Baltimore, Johns Hopkins, Boston, University of Michigan, Memorial Sloan Kettering, Dr. William Travis, the NYU Langone Health, Dr. Andre Moreira, University of Pittsburgh. I'm blanking on the name of the person. He was a great pathologist who recently expired. But there is Dr. Sonia Dasik at the University of Pittsburgh, MD Anderson, Cesar Moran, and Texas Southwestern Dallas, University of Washington, Seattle. And then there's one program in Toronto, Ontario, University of Health Network. Even though I must say that Andrew Churg is one of the most senior pulmonary pathologists at Vancouver, Canada, but I don't think there's any fellowship program there with Andrew Churg. But I think you can always write to any of these pulmonary pathologists if you're interested in doing an observership or something like that. Depending on the availability, they can take you. But this is all available in Pulmonary Pathology Society website. And in addition to this formal kind of fellowships, so these fellowships are, again, the ACGME, the accreditation by graduate medical education, that's kind of an important if you're an IMG, the International Medical Graduate, because that helps you with your immigration process and the paperwork and everything. That information you can find in the respective websites with the contact details and everything. But if you have any questions, if you call the program coordinator or email them, they should be able to give you an accurate information. But otherwise, thoracic pathology training or pulmonary pathology training is available as elective rotations during other fellowships. So you might be doing a surgical pathology fellowship, then you can also do a month or 2 months of pulmonary pathology training. And it can be combined with other fellowships. That's what I'm trying to say. Qualifications. So your basic medical degree or the M.B.B.S or the M.D. diploma, that is important. Then USMLE for US, the Canadian, I'm not sure. I have to check the requirement. There's one program there. I think you have to pass a Canadian entrance examination. But you need an residency program in pathology, anatomic pathology or APCP training. Just anatomic pathology is 3 years. You can also do APCP, which is 4 years. I did APCP training because more training, it's always helpful because it will help you in somewhere, some aspect, it will help you. And generally, this preference is given for people who have already completed surgical pathology fellowship. Again, it's optional. Research experience is always optional. They would appreciate if you have research experience, but that's not a deal breaker. Again, with or without PhD, that's not a deal breaker. what is more important is your interest in pulmonary pathology, and if you had done some observership or a kind of a small rotation with the person or with the program where you want to go, that will definitely help you get in there. The other important requirement, or it's not a requirement, other important tip I can give you would be a research kind of project in the field of pulmonary pathology would also help you giving for you to give a national kind of presentation, one of those meetings. The meetings can be an pathology meeting, national level pathology meeting by CAP, College of American Pathologists, or American Society of Clinical Pathologists, or more difficult one or more competitive one is the USCAP, the United States Canadian Academy of Pathologists national meeting or annual meeting. They say that it's difficult for people to accept your posters or papers. So if you can get those in there, then that will help your application. So that's some of the requirements. Then how does an academic year look like? Or it usually begins in July of each year. And the applications are usually made approximately 18 months before the start of the fellowship. I'm just giving you the maximum kind of period. Some they do 1 year before the start of the fellowship. And again, most fellowships are for a year. Some will have an additional research year. Some of them, again, what I did was I did 1 year of surgical pathology followed by pulmonary pathology. Generally, most people do this 2 fellowships kind of a thing at the same institution. Sometimes they do 2 different kind of specialties, most of the times, not sometimes. They'll do, like, the most common combination I've seen is surgical and pulmonary, but surgical and cardiovascular pathology fellowship, that's another most common combination. But I've seen surgical pathology with cytopathology. Each 1 year, then they will combine those. Or cytopathology with pulmonary pathology. Especially I saw somebody doing that in Memorial Sloan. So there are various combinations you can do. So when you're a fellow, when you are in the fellowship, what kind of responsibilities you can expect? So the service responsibility is the most important one, where you sign out both in-house cases and the consults coming from outside, because all these are bigger academic institutions, so they have a pretty busy consult cases coming from other institutions, community practice, or even other smaller private labs and that kind of a thing. Then frozen section rotation. And there are several educational conferences in this as the responsibilities of the fellow. But the most important would be radiology pathology conferences, which are very important for understanding, especially the interstitial lung diseases. Then teaching and research projects are important. So other than the US training, I found 2 in options in Europe. Each one is 3 months training. But again, it's up to the individual institutions if they can take you, depending on your depending on what they determine to be the eligibility criteria. But you can always write to them individually, and you can find out from them. So there is no formal training programs available outside the US, and these can change every year. So you just have to search for them as they open up, and if you're interested to pursue further, you write to them and find out what exactly they would need you to do. So currently, I've been practicing pulmonary pathology. So this is my 4th year as a consultant. So bulk of my practice is lung cancer diagnosis and prognostic kind of thing. That means whenever I diagnose a lung cancer, I get the tissue and send it for molecular testing to identify any targetable mutations because there's so many definitive drugs available now. To give you an example, we started with EGFR mutant lung cancers. Now we have drugs for NTRK rearrangements. Then the drugs are also available for HER2 mutations in the lung. That's the latest one. Then there are drugs available for ROS1 fusions, ALK, RET, and everything. So there are about, I think, 16 or 17 targetable kind of genes available right now for lung cancer. Then you must have heard in the television ads about Keytruda. That's nothing but the PD-L1 inhibitor. So the PD-L1 testing is very important if the lung cancer patient is eligible for immunotherapy, which is by Keytruda. So the bulk of my practice is lung cancer, diagnosing them. Then others are pleura, mediastinal conditions, thymomas. I do look at thymomas. Lung transplant. We do more heart transplants than lung transplants here at VCU, but there is a big lung transplant program coming up in VCU soon. But if you look at other academic institutions, the lung pathologists would also do lung transplants. And then the other, say, for example, important chunk of my practice is interstitial lung diseases. And most of the time, the interstitial lung diseases in that most commonly is acute interstitial lung disease in the form of DAD and organizing pneumonia. Then the other half of that would be chronic interstitial lung disease like usual interstitial pneumonia, non-specific interstitial pneumonia, hypersensitivity pneumonitis. Rarely I do get pediatric cases in terms of CPALMS or cystic sequestrations. So the interstitial lung disease program, what we have is more of a multidisciplinary kind of setup where the biopsies has become smaller and smaller. So the pathologist would give a diagnosis, and then with the radiology, we have something called as multidisciplinary assessment, and we make a final diagnosis combining the findings from all the three different things: pathology, radiology, and clinical. That's the pulmonology. And we look at all the tests we do. For example, in this case of hypersensitivity pneumonitis, so this person had a hypersensitivity pneumonitis panel positive for Aurea basidium purulans. So it's a common mold available or colonizing in the AC systems. So older AC systems and that kind of a thing, places where there's a lot of flooding and stagnant water accumulations or older homes. So there's an issue with this. So the interstitial lung diseases has become more of a multidisciplinary kind of diagnosis now. So briefly, I'll tell you about organizations and then I'll open up for questions. So I've already mentioned about the Pulmonary Pathology Society. There is something called American Thoracic Society, then International Association for the Study of Lung Cancer, then Inter-Society Council for Pathology Information. Again, the disclosure here is I'm a part of the board of the Inter-Society Council for Pathology Information, but it's a voluntary activity, no finances involved here. But the good thing about this society is it's a central information source for pathology. So you should check this website, pathologytrainingorg. So there's information for students, residents, fellows, and researchers. Everybody who wants to know about pathology, you have information here. So I'm just giving you two examples here. You can see a journey to success career pathways for biomedical scientists in pathology and lab medicine, or satisfying medical. So you have information, tons and tons of information about this. And there is information about the available programs, specific programs like in Virginia or in New York or California, the list of residency programs for pathology, the list of fellowship programs for pathology, the different specialties for pathology. All this information is in this website. It's available in this website. So it's a great resource. So American Thoracic Society, I look at this more for guidelines and official documents. For example, you can see a diagnosis of hypersensitivity pneumonitis, diagnosis and detection of sarcoidosis. So they have all the criteria, the pathology criteria, the clinical criteria, and the radiology criteria. For example, IPF, idiopathic pulmonary diseases. So they have all the criteria listed here. So, and these are a combination of societies coming up with these guidelines. Like you can see here, ATS, that is American Thoracic Society, ERS, European Respiratory Society, then Japanese, Latino, Latin American society. So all the societies come together and they review all the material, the scientific literature, and then they come up with a guideline. So it's important for us in the pulmonary pathology or in the pathology world to look at this kind of guidelines so that we know that we are using them for making the best for our patients. Then same thing for the study of lung cancer. So here you'll find tons and tons of good, great information. For students, you'll find early career opportunities. You can find research committees and projects. You can find meetings and knowledge-based kind of questions or like courses. And there's also like, you can, if you're interested in a project, you can apply for grants. That grant opportunities are available. So there's tons of information available. Then pathology outlines gives you some list of pathology books, means the books information you can find anywhere. If you Google them, you'll find, but you can see there's so many different books available for pulmonary pathology. And then I want to tell you about this WHO Blue Books. Means if you're at a medical student level, this might be early for you, but if you become a resident in pathology, then each of these organ systems has got a WHO tumor classification series book, and they're all like blue colored cover. So it's at the back of my back of me in the cupboard there. So the blue books. So these are by the WHO people, and these are done by the experts in the field, and most of them, they're authors of their own articles and everything. They published a lot, and they're pioneers and experts in the field, and they write these chapters, and they compile the most up-to-date information and everything, and they bring to us. So a good resource when you get into residency in pathology. Again, the ICPE website also gives you a lot of career kind of job board options. Like it takes you this different websites where you'll find a lot of job opportunities, like pathology job opportunities, different specialties that broken down into different specialties, geographic locations. You'll find those kind of information. And also, you can see this is from Pathology Outlines. This is only looking at jobs for pulmonary and cardiovascular. So from 2017, you can see the jobs in cardiovascular and pulmonary has gone up. So 2022, you can see almost up to 700 jobs. So that's just in one country. So there was a statistic, again, I can't remember the journal name. There are about 500,000 pulmonologists, but there are less than 100 or 200 pulmonary pathologists. So you can see the difference. So if you're looking at social media, there's some lot of good people you can follow who do pulmonary pathology. These are all expert pulmonary pathologists. That's a Twitter handle of Pulmonary Pathology Society. Then Sanjay Mukhopadhyay, the Cleveland pulmonary pathologist, the author of the first COVID-19 autopsy article. Then Jen Boland, Matt Cecchini. So there's some good people you can follow. They post interesting cases and relevant cases of pulmonary pathology. And organizations, I told you some of them before. And then I wanted to show you this. So some of these pathologists like Sanjay and Gerard Gardner, we consider him as pioneer of the social media in pathology. So he does soft tissue and dermatopathology. He has got a lot of videos, both on YouTube and also on this. So where it's all free. They will just take you there, and you follow the link, and then they would discuss this case or case-based presentation. They'll show you the microscope image, or they have a video where they will scroll through the image, the slide, the scan slide, and they will tell you the differential diagnosis and then the different appearances of the different cells and everything, and then how to formulate a formal diagnosis, and what are the immunostains or the workup you need to do in difficult cases or challenging cases. So that's a valuable or extremely good educational kind of opportunity or resource. And then yours truly, I'm also on Twitter. You can follow me on Twitter and ask me anything about pulmonary pathology. And yeah, we also have some YouTube videos on all these different topics in pulmonary pathology. So fresh air with Sanjay and Matt. So you can see that's Irene Sanson, the pulmonary pathologist from Spain. And that's me with Matt and Sanjay. So we're talking about this UIP case, which has some areas of NSIP. So whenever you see areas of NSIP in UIP, you still call UIP. So these kind of little tips and tricks of the trade will tell you in this little educational stuff. So I think with that, let me conclude that pulmonary pathology is a great subspecialty with growing number of jobs, opportunities, and continued clinical significance in this changing, ever-changing world of COVID and whatnot and whatnot. There's a social component to it: smoking, vaping, all kinds of new stuff coming. And then it's at the cornerstone of clinical service, research, and teaching. So with that, I'll end my talk and open up for discussion, questions. Your questions and comments will be appreciated.
Thank you so much, Dr. Pillappa, for your time. We truly enjoyed your presentation. We will now open the floor to any questions that anyone may have. So please put on your mic, camera, or you can type your question in the chat. So we had a feedback activity, Dr. Pillappa, where the audience, they typed a comment on your presentation, which is seen on your screen here. So some said it was awesome, enlightening, informative, holistic, educational, useful, excellent, very pleasant, inspiring, interesting, and intriguing, captivating. We do have a few questions sent previously. One stating what is the most common pulmonary pathology.
What was the question? What's the common what?
What is the most common pulmonary pathology?
What do I see commonly in pulmonary pathology? Yeah, the lung cancer cases, they make the bulk of my practice. Again, the lung cancer cases, mostly they're adenocarcinomas or squamous cell carcinomas. Most of them, they're being resected. Like usually we get this pieces of lung with the cancer, with the nodule, where they try to resect around the nodule so to get negative kind of margins. But before getting to that point, many of these patients already would have gotten a needle core biopsy, like they put a little needle into the mass lesion via imaging. And many of the times they do what is called as endoscopy, endoscopic kind of ultrasound guided sampling of the lymph nodes in the mediastinum to see if the cancer is localized to the lung or spread into these lymph nodes. Because if the cancer is already spread to the lymph nodes, then there is no curative kind of surgery. Then the patients would get what is called as chemotherapy and radiation because the cancer is already metastatized to the lymph nodes. So it's no longer localized. So they do this endoscopic guided kind of final aspiration biopsies or aspirations of the lymph nodes for staging purposes. So that's the most common type of specimens I encounter in pulmonary pathology practice. Less often, the interstitial lung disease are less often, but just now I got a text from the pulmonologist saying that there's a specimen coming up. So generally, we have a good communication with the pulmonologist and the radiologist that the interstitial lung disease, if it's coming, they would tell us about it and everything. But the lung cancer, it comes every day. Yeah.
Okay, so another question someone sent was, how does a lung affected by COVID-19 look gross and microscopically?
Yeah, the grossly you will find depends on the amount of damage it has caused. So COVID-19 causes what is called as in pathology term, like I showed you, DAD, diffuse alveolar damage. So it causes acute lung injury. The $2 word for acute lung injury in pathology terms is diffuse alveolar damage. That's what you see in microscopy, but the DAD can be seen in so many other etiology. So what I'm trying to say here is the DAD is not specific to COVID. Unless there is a clinical component saying that the patient is COVID positive. And nowadays we can also test the specimen for PCR for COVID. So the tissue blocks can also be tested for COVID. So in COVID, other than the DAD, we can also see bronchopneumonia, like a secondary bacterial infection. And they sometimes, because of the severe infection, they can be infarction of the lung tissue. And depending on these changes, on grossly, you'll find discoloration, areas of infarction, or even cystic changes. All these changes can be seen on grossly. But that's a good question because there is no specific finding for COVID saying that, oh, this DAD is because of COVID, because the DAD can be due to various conditions. It can be due to vaping, it can be due to infections, other infections. It can be because of toxic inhalation, like smoke, fire, or even toxic fumes, like accidents. All those can cause DAD. So with COVID-19, you will find DAD as the most common pathology findings, but you cannot tell it's because of COVID unless you have that scenario that patient is affected by COVID infection.
Someone else asked, what are the best ways to maintain proper pulmonary health in highly polluted society, for instance, with constant fossil fuel emissions?
Can you repeat that one more time, please?
Sure. What are the best ways to maintain proper pulmonary health in highly polluted society, for instance, those with high fossil fuel emissions?
You know, that question seems so simple, but the most difficult question to answer, because how do you avoid the pollution getting into your lungs? Can you really avoid it? No, you can't. Means obviously breathing fresh air is obviously good with no pollutants or anything like that. But otherwise, avoid smoking and good exercises and good diet and that kind of a thing, adequate hydration. But otherwise, breathing fresh air is always good. Yeah, that's that question. It doesn't have a straight answer. Yeah.
Thank you so much, Dr. Pillappa. So if no one has any questions, I will now like to move on to the vote of thanks. So I hope you all had a wonderful and learning experience. At this time, the feedback form link has been sent in the chat, and we would like you to take a minute to fill it out. It will be greatly appreciated for documentation and improvement of our future events. Alfred North Whitehead once said, "No one achieves success does so without the help of others. The wise and confident acknowledge his help with gratitude." Firstly, I'd like to thank our future speaker, Dr. Raghavendra Pillappa, who despite his busy schedule, graced us this evening with an amazing and enlightening presentation, where we were all extremely grateful to learn about pulmonary pathology. Whilst we are most happy that you were able to give us an insight to the behind the scenes of pulmonary pathologists, we are hopeful that your audience was able to take pertinent notes and was reminded, if not educated, on the importance of the topic that you have presented around. Ranjiva Brijlal, the president of the Pathology Club, sends his apologies for his early departure, but applauds you, Dr. Pillappa, for your volunteerism to deliver this genuinely sterling and passion-filled talk on a subspecialty most fitting for the times we are in. We would also like to extend our gratitude to Dr. Catherine Morris, one of our inaugural executive directors, for your presence this evening. We appreciate your endless support and thank you for playing a key role in supporting us throughout our journey thus far. We thank you all for taking your valuable time, effort, and consideration in the investment to nurture and properly establish the future of pathology. It is not only an act of success, but one of the greatness showing us the path that you all have walked. Last but not least, ladies and gentlemen, I would like to thank you all for accompanying us tonight and making our event a success. And we look forward to your continued support. To all our UB students and staff across the 3 campuses at the University of Ottawa and Eastern Ontario Laboratory Regional Association, and especially to you, our specially invited guests. Thank you, thank you, thank you. Thank you all for joining us for this, our 14th installment of CPALMSI. And we hope to see you at our future events. Take care and be safe.
Yeah, thank you very much to the organizers and to you also. And also thank you, Catherine, for this opportunity, and thank you for making it today. And thank you to the president, the founder, the vice president, and wish you guys good luck. And you can follow me on the Twitter, and if you have any questions, feel free to ask me.
Thank you so much, Raghav.
So alive, make it last forever. Stop in time, yeah, I'm surrendering. Hold tight, chemicals collide. Hold tight, hold tight, hold tight. Dripping lights paint the skies, all because